We're going to get started on our lunchtime symposium on integrating immunotherapy into resectable lung cancer, how to modify treatment trajectories and recognize multidisciplinary care pathways. I'm Jessica Donington. This is Jonathan Spicer. It's our special morning today. You'll see us till you can't take it anymore, but hopefully we'll continue to have a great educational session. We need to thank PeerView for providing this session. AstraZeneca, BMS, and Merck have provided educational grant to help support this symposium. You can also visit the peerview.com site to review this data and look at other PeerView related information. Slides will be available for download. So our goals today are to enhance your understanding of the latest evidence supporting the use of immunotherapies, augment your ability to identify appropriate candidates for this, and improve the multidisciplinary collaboration to optimally integrate these therapies into the treatment plan for patients with resectable lung cancer. So what New Frontiers Immunotherapy, we're going to go over the core evidence for stage 1 to 3 resectable patients. So I think some of you or many of you have seen a table similar to this from me in the past. It really goes over some of the key information on both the neoadjuvant, periadjuvant, and adjuvant trials in this space. There is a lot of data. It has come out fast and furious. And I always talk a lot how much these trials are similar rather than they are different. The newest trial in this slide is BR31. This was just presented at ESMO. It is an adjuvant trial with durvalumab. And so far, we have not really picked out significant populations with survival advantage to date. These are the protocols that have FDA approval. So you can see the Checkmate 816 in the neoadjuvant setting, both in POWER and Keynote 091 protocols using atezolizumab and pembrolizumab in the adjuvant setting. And now in the periadjuvant setting, we have approvals with durvalumab and pembrolizumab based upon the Aegean and Keynote 671 trials. So a lot of new data has come out, and what we've decided today is to focus on these 3 questions. What is the contribution of immunotherapy to overall survival in both quality of life and overall survival? How do the neoadjuvant and periadjuvant immunotherapy strategies compare? And how do we tackle some specific subgroups with each of these? And I think for the first part, I'm turning it over to Dr. Spicer.
All right, thank you very much. First, so we're really going to focus on OS and health-related quality of life. So the only data we have in the adjuvant setting is from the Empower 010 regarding subgroups that have overall survival benefit. And the group that has the most benefit is the PD-L1 greater than 50%. The approval here in the US is for greater than 1%. But in places like Europe, Canada, and a few other countries, it's only in the 50% or greater, because if you were to look at the 1 to 49, you see that these curves actually overlap quite a bit. But it is a not subtle effect in the 50% or greater. And for your patients who happen to go up to upfront resection, are able to get at least 1 dose of adjuvant chemotherapy, the receipt of a year of atezolizumab is clearly of great benefit to those patients in terms of prolonging their life, and that's important. What about the pure neoadjuvant trials? So we reported on the 4-year outcomes from Checkmate 816 back at ASCO this June. These are the longest follow-up data we have from any of the neoadjuvant or perioperative trials. And the difference is sustained. So you have 71% overall survival at 4 years versus in the neoadjuvant chemo nivolumab versus a neoadjuvant chemo, it's at 58%. These are great results for populations primarily composed of stage 3 and 2Bs, but it is not yet statistically significant, and it may not end up being statistically significant when we come to the final 5-year analysis. You can see the hazard ratio is 0.69, but we have not crossed the boundary for statistical significance. I think it's a clinically important difference. You see early separation of the curves, but it was a small trial of 358 patients and maybe just underpowered. I'll remind you that overall survival was not in the primary endpoint of this study, and so some of the alpha is consumed for the analysis of PCR and EFS, which were the primary endpoints, dual primary endpoints for this trial. Lung cancer specific survival seemed to be improved as well. Again, 79% versus 66% with the hazard ratio of 0.62. We have data on OS that was presented in relation to the recent ODAC with the FDA and the approval of the AGN regimen. This is a trial for which the primary endpoint was pathological response and EFS. So OS was a secondary endpoint, and it's not yet statistically mature. I think there's only about 35% of the population is mature enough, and so I suspect this will continue to evolve in a positive trend, but is not yet statistically positive for overall survival. The lung cancer specific survival seems to be improved with the receipt of durvalumab, but this is an endpoint that's not quite as robust, of course, as overall survival. So Keynote 671, as you may have heard earlier this morning, is the only trial using immunotherapy in any fashion for resectable non-small cell lung cancer patients to be positive for overall survival in the intent to treat population. This is all comers. This is at the 36-month second interim analysis, and we have 71% overall survival at that landmark versus 64%. And you can see there's still a lot of censoring on those curves, so we hope that it'll continue to mature in an even more positive and showing even further benefit over time. That is great, but it would be a major problem if it came at a significant cost to patients in terms of quality of life. Of course, it's not assessing financial toxicity or time toxicity in terms of the requirements of the patients to complete the regimen, but in terms of a comparison to a placebo, you can see that the red and blue lines are completely overlapping. And if you go into all of the subdomains of the QLQ-C30 questionnaire, they are all quite similar. The only moment in time where there is a decline in the quality of life is shortly after surgery. And you'll see, and this has been reproduced in the other trials as well, where you'll see a rather quick return to baseline. I think this is really important when you're in your tumor boards and discussing, should this patient go to chemo-RT or adopt a surgical course? You can tell your colleagues and your patients that the vast majority of patients will return to their baseline quality of life within a few weeks of completing surgery. That's very valuable, and I'll tell you, there are no such data in the chemo-RT world. All they can tell you is from the point of randomization to adjuvant durvalumab, they don't have the data from the point of diagnosis, evaluating prospectively the patient's quality of life through 4 to 6 weeks of chemo-RT and the time after and what happens to them, those who do or don't make it to the adjuvant immunotherapy. So we have very strong data in the surgical world to support the use of this approach, and I think that's great news for us. But what do we have to do as surgeons to ensure that we offer the best results for our patients? So number one, get your patients to surgery. So select patients who are operable and operate on them. The hazard ratios are favorable for the patients who got surgery. Do the operation that is required to get all the disease out. There's benefit whether you do a lobectomy, bilobectomy, or pneumonectomy. So get the tumor out, get it all out. Get an R0 resection, because if you don't, hazard ratio is not so advantageous. So pick patients in whom you think this is feasible, and once you take them to surgery, ensure that this is done. Use frozen section liberally, and call another partner if you think you're struggling to get that R0 to make sure it is done. So I think these are really, really key points. And there are data to help us get there. If you're worried about the necessity to complete the operation by a minimally invasive technique, don't be. because the return to quality of life, if the patient has a thoracotomy or a minimally invasive resection, at least in the 816 trial, is the same. So don't sacrifice the completeness or safety of the operation for the sake of completing it minimally invasive. This is super important. And I'm going to, if we have time, get to a case at the end where I may have not done this. And these data have helped me be more expedient to convert if I'm struggling by a minimally invasive approach. And surprisingly, the return to baseline quality of life, regardless of extent for lobectomy or pneumonectomy, seems to be quite swift, the green curve being the chemo-nivolumab patients. So if you pick a patient who is fit enough to have a pneumonectomy and you perform it, surprisingly, their quality of life returns to baseline rather rapidly and stays there throughout the course of their trajectory. And then we have data from that Dr. Cascone published with the 77T team in New England Journal. And I think this is super important. This is time to definitive deterioration in quality of life. So the receipt of perioperative nivolumab not only improved event-free survival, but it slowed definitive deterioration in quality of life. And that's what our patients really want. You can tell them this regimen will make sure that you maintain the best possible quality of life for the longest period of time for the disease that you have. And I think now we're going to go on to Dr. Donington's second part, the challenging peri-op versus pre-op question.
All right, so this morning, Jonathan introduced this work which was presented at World Lung, looking at those patients in Checkmate 816 versus those patients in 77T who got one dose of their adjuvant immunotherapy. This to date is the best analysis we have. I was a co-author, so I am biased. I think these types of exploratory analysis are not perfect. They are not randomized trials, but I think they give us good signals. This was individual patient data. The weighting was, which trial we weighted to. Did we weight to the Checkmate 816 or to the 77T? The biggest difference between the populations, surprisingly, was geographic. Baseline characteristics were otherwise incredibly similar. And then this is the landmark event-free survival from the time of surgery. The statisticians felt very strongly that there was no way we could do this except from the time of surgery. And we do see a slight survival advantage for the peri-adjuvant approach. We then did several subgroups. So first by pass CR and no pass CR. And again, not a lot of difference between those patients who had a pass CR, whether they got the adjuvant or not, but there seems to be clear separation from those patients who had residual viable tumor. Also, a little bit of a surprising signal with regard to PD-L1 status, where we saw a greater benefit with the addition of adjuvant in those patients who were PD-L1 negative. Is this conversion of the tumor? Is this the need of more treatment? It's a little bit hard to fully call that one. And then a little bit of stage-related data, kind of, again, a little bit surprising that in this, the benefit we saw with the addition of the neoadjuvant was regardless of the stage, but looks like the curves are a bit more separate in those patients with 1B or 2 disease. This is data from the Keynote 671, again, kind of, separating curves. Sometimes we see these all together, but I think the advantage of the neoadjuvant might be more pronounced by kind of separating those and looking at what the post-op implications are. And I do think that we see the greatest advantage in those patients with residual viable tumor, with a kind of growing and sustained separation of those curves. And now we're going to tackle some specific subgroups. And again, we started some of this morning. I'm quickly going to run through some of the data which you saw this morning. This is the Aegean data comparing the N2 population to the entire intention to treat population. And again, we see a very similar pattern in terms of path CR and major pathologic response. And then here is the event-free survival, again, with the N2 population to your left. And the curves look very, very similar. This is the surgical data, which I did not show you. It's super small, but I hope you can see that we really didn't see any difference in the type of surgery performed, complications related to surgery, extent of resection, and completeness of resection. They appear to be quite similar between the N2 and broader population. And then this is the data from the Checkmate 77T. Here we see the N2 versus non-N2. What's brought out in the lighter bars are those patients who went to surgery with an R0 resection. So not surprising, we see higher rates of both path CR and major pathologic response in those populations. Here is the path CR data. And again, this is now single station versus multi-station disease. And again, it's hard for me to say that these patients don't belong at surgery when I can see a 29% path CR rate in a multi-station N2 patient receiving chemoimmunotherapy. Here is EFS data, and again, here we're looking at the N2 versus non-N2 populations, and the EF benefit does appear to be larger in the N2 positive, with a similar kind of survival curve in the treatment arm. And again, very similar to what I showed you this morning between the non-N2, single station N2, and multi-station N2, and kind of straight across, very similar survival in the treatment arm, and kind of dismal survival in the control arm, especially for multi-station N2 disease. Now we're going to go on to ctDNA, and I think this is just so exciting how much this has moved into this space, and again, how consistent our findings are from one trial to the next, telling us that this is a real signal, even if all of the science isn't perfect here. So this represents what Dr. Harpel showed us this morning about ctDNA clearance from the Aegean trial, and that clearing ctDNA was really an incredibly strong marker for event-free survival. This is ctDNA clearance from the Checkmate 816 trial. 56% of patients in the treatment arm cleared their ctDNA, and once again, we see a really strong correlation between clearance of ctDNA, and in this case, that's an overall survival curve, not event-free survival. And then Checkmate 77T. So within the nivolumab arm, we see 66%, not so different from the Checkmate trial, clearance of ctDNA in those patients who received the nivolumab as part of their induction strategy. And we can also see that in the kind of correlation in the bars closer to me of what does it mean to have ctDNA and what does it mean for path CR. And so no patients who didn't clear their ctDNA had a path CR. But half of the patients who did have clearance of their ctDNA did have a path CR. So I think these are two markers working hand in hand, and I think we still have to pay strong attention to both of them as we talk about what happens next. Very interesting, this looks at ctDNA recurrence from the Checkmate 77T. So in all the patients who had their ctDNA cleared and then went on to their adjuvant therapy, about 8% in the nivolumab arm compared to 20% in the control arm had a recurrence of ctDNA positivity. And I think that's kind of an important marker. And again, how do we correlate all of that with path CR? So again, ctDNA recurrence in those patients who had a path CR, much less for nivolumab than without. And it's kind of still 4%. So again, all of this needs to be taken together. I actually really love this swimmer's plot, which tells us about these patients who had this recurrence once they had already cleared it in this trial. The first 4 lanes are those patients in the nivolumab arm, and the black dots or squares represent where they had their ctDNA recurrence, and yet because that was kind of a central lab, it's not like the treatment physicians necessarily knew this. And you can see that many have gone on and never received additional therapy or had clinical evidence for recurrence. That's really not true in the nivolumab, in the control population, where most patients who had their MRD recur quickly went on to receive additional therapies, and we even saw a couple of deaths.
We're getting really good at this. We're almost done.
We're almost done. We're going to have lots of time for questions. So if you guys don't put anything in, we're just going to start singing and dancing up here.
There's always stuff to talk about. So I'm going to show you a case, and really it's about, I'm going to try and illustrate how it'd be nice if we had all this information going into the OR, how it might influence our thinking, especially when dealing with difficult cases. And this is me struggling over 6 minutes, which was more like 3 hours of torture before I finally, I guess, did the right thing. So this was a 69-year-old patient, Inuit, active smoker with this left lower lobe mass. She had an EBUS that showed 4RL and 7 were negative. There was squamous cell carcinoma with PD-L1 50% in the 11L lymph node. And so she was staged as a T2B N1 by EBUS PET CT and CT head. She had excellent lung function. She was a hunter and liked to be active. And you can see the response here post 3 cycles, which she tolerated remarkably well. She actually flew back between Montreal and the Great North to come get her staging scans. And so we went straight to surgery. And I was thinking this is going to be a chip shot and going to be an easy case. And I guess the first hint that it wasn't going to be so easy was this adherence over the aorta. It was a little bit more stuck than I expected. And anyways, plug along and try and get that cleared up. And I want to thank my fellow Luciano Bulgarelli, who did all the video work and edited this video. So here you see our dissection on the posterior hilum with the vein. It is evidently stuck, and now we're trying to go into the fissure and get that level 11 lymph node, which is positive. You can see I'm kind of the hook cautery suction kind of surgeon, pretty rudimentary stuff. This level 11 looked great, and we'll see, we'll take it out in a moment. It's a little bit stuck on the upper lobe, so we fired a stapler to get that cleared off. And right now, at this point, I'm like, this looks like it'll be a MIS case, and we're not really terribly concerned. That lymph node's coming off nicely, and I'm trying to complete the fissure posteriorly, and just sort of gently pushing the PA down to complete that. It was nice that she had a actually friendly fissure. So I was, everything was going according to plan so far. But I started to wonder, okay, so you start integrating the piece of information that you have. You have a partial response on the scan. The patient has PD-L1 50%. So there's a possibility that this patient has a PCR. It's actually a pretty high probability. And should you let that information influence you operatively or not? I'm just going to, here we remind you of the post-induction scan showing this level 11 lymph node that is sizable and hasn't really responded super well. And maybe I underappreciated that when I briefly looked at the scan before going into the OR. And here we are trying to sort of yank out that lymph node. And at this point, I thought it'd be useful to know if this, because it looks like it's a bit stuck on the PA back there, useful to know if this lymph node has disease in it. So I sent it for a frozen section, and that frozen section came back negative. But you can see there's like some white stuff there, and it doesn't look good. And could there be something that might be positive back there? I'm struggling to create a plane between the bronchus and the PA. So I tell myself, okay, let me take the vein, maybe with, get better exposure, I'll be able to separate that. No go. So at this point, I'm like, okay, I'm not going to persist here without getting some control. And I think if you're going to do these things minimally invasively and you're starting to get into a dicey situation on the PA, it's wise to try and get control. So here I'm getting level 5 and then dissecting above and below the left main PA so that if something terrible happens, it's relatively easy to get control and convert under control. So you can see that's kind of, for me, that's enough that if something terrible happens, I can at least get a clamp on. And onwards.
Yeah.
Impossible with the hook or even Bovie to really clear this off. So start going with some scissors. And I think if you're a good robotic surgeon, this is probably a case where, the improved dexterity would be nice to have. But I'm not making any progress. So I tell myself, maybe if I open, hours are going by now. Now it's starting to take time. And I said, well, I'm really stubborn. Maybe I should try and sharply divide the bronchus. I'm a little embarrassed to show you guys this, to be honest. But anyway, so learn from my mistakes. So let's divide the airway and see if that will give us a view to the back of the PA, which sometimes it does. And this is what I would do open if I was struggling. And so here we go, being a little bit more bold, trying to cut things that I don't know what they are. And there we go. Oh, there I did it. So now I put a clamp on and we convert and we do a sleeve. And maybe I could have saved myself 2 hours, her more anesthesia time and a lot of struggling and a lot of risk had we not just known that her quality of life would be back to wherever it would have been had I done it minimally invasive or not. Now, she had a complicated course. Unfortunately, it took us almost 2 weeks to recognize that she had adrenal insufficiency and treat it. She wasn't presenting in a typical way, but it seemed to be an IO-induced adrenal insufficiency. She had post-operative pneumonias. She was in the ICU getting bronched and cleaned out. Could she have had an easier course with a pneumonectomy? Maybe. And so all these decisions are really torturing us in the operating room. I mean, if she had cleared her ctDNA, would that have influenced maybe the approach? All these added pieces of information, I think, are bit by bit going to infiltrate our practice and inform the decisions we make when we take these patients to the operating room. So there's no big lessons learned here, but I think my takeaway is when I have these complicated cases, I'm much more prone to convert early than I might have been a year ago. And it's great exposure for the fellows to do some open cases, and the patients do just fine. And I also struggle with the idea of, should you go ahead and do pneumonectomy in this patient? She had residual disease. The margins ended up being clear, but I think she would have gone home post-op day 3 after pneumonectomy with those lung functions and the fitness that she had. And now that we know what the EFS benefit, even for the pneumonectomy patients, and the OS benefit for the pneumonectomy patients, maybe when the patient is really fit for it, that's the easier operation for them to recover from. So just some thoughts there on that case. I think we're on to the Q&A, and we have about 10 minutes now. So it's not too late to enter your own questions for us to discuss.
What's your approach to talking with more the conservative oncologist about adopting this? I know some places the surgeons tend to be more at the forefront and pushing neoadjuvant therapy. Other places, like in U of M, a lot of our patients come from different parts of the state, and the oncologists are pretty much at the front lines as far as recommending, neoadjuvant chemo, radiation, or whatever. So what is your recommendation as far as approaching that strategically, as far as trying to encourage them to incorporate this in their practice?
I practice in a bit of a different environment up in Canada, but those discussions always come up. People, you have early adopters and late adopters, right, wherever you are, and it can be hard to work across institutions. But there are a lot of opportunities that are offered to patients via a neoadjuvant strategy that, and I think we've built up a pretty strong prehabilitation effort at our center. Patients don't always come to us in the most medically optimized state, and so that is a great opportunity, to get smoking cessation accomplished, to get all their diabetes under control, hypertension, all these things. You buy yourself some time to get them really tip-top shape to the OR. And I don't know if it's a selling point to the medical oncologist, but I don't like what would they rather do? Is it they'd rather do chemo RT, or what is the alternative that they would rather you just operate up front? What are you dealing with?
Yeah, I think just more so like, oh, yeah, I'm not sure about IO, the data is this and that. And we're just, my partners are trying to get them to adopt it, even more so at our center, right? Still just a bit more hesitancy and, the obscurity behind the data. So I'm just thinking like, what are the discussions elsewhere to get, oncologists to embrace this more openly?
So I always think that when we started with Checkmate, I always thought the cell was easy. It was 3 and done versus 12, and it was like so easy. It was like shooting fish in a pond. Sure. There. It was easy. Now it's a little more complicated because we are seeing that most patients are going to get peri-adjuvant, but we also have watched the results mature, and they really are consistently and strongly so good that I think you just have to show them the data. Yeah. I really think that's what it gets down to, and I just don't think there are big safety concerns that are out there. While 20% don't make it to surgery, it's more like 2% that don't make it to surgery for toxicity. Yeah. 20% don't make it typically because we made a bad decision.
And I would say develop your own data. I mean, in our center, I would say 5%, maybe less, who don't make it to surgery. So I think you have to know the data. You have to be able to compellingly propose it to the oncologist. I get the sense that most of the oncologists that folks work with in the community here are general oncologists who might not be going to thoracic meetings. Right. So I remember 2016, I wanted to operate on N2 disease. I don't know why. It was an idea that we should operate on N2 disease. And we had a dinner and we talked about it and we looked at the evidence and we brought everyone together. I think you have to do that sort of team building stuff with all the folks you interact with.
Thank you.
There's some good questions here, but
go quickly from the microphone and then we'll tackle these.
Oh, thank you. I'm Hao from Brigham and Women's Hospital. So I have a question is that from the Checkmate and the Keynote study, we know that percent RVT is a reasonable prognostic factors for patients. And do you think it's reasonable for us to use the same inductive therapy for patients with the percent RVT over like 70 or 80%? I mean, if the patient didn't get response in the inductive therapy, so why would we use the same inductive therapy after the surgery?
Well, I do think this is where our next wave of trials is going, because I think we have now from these trials recognized, those patients that do very well, kind of well, and then those, you're right, which don't appear to benefit. And so I think that is the next wave of trials. Yeah. And I think I'm not a medical oncologist. I think it would be hard to take someone who had 80% residual viable tumor and put them on a similar regime. At the same time, it's not like we have better in our back pocket right now.
Yeah, maybe we need to see some more combined therapies for that patient didn't get a well response. Yeah. And also I got another question is about the very interesting data about the stage 3A and with N2 and non-N2 subgroup. Because the tumor draining lymph nodes has a very important responses among the tumor microenvironment to get the tumor to respond to immune therapy. So for N2 disease, if the tumor has the metastatic lymph nodes, usually the lymph nodes show the immune suppressive microenvironment. So I'm very curious about what's the behind the mechanism of that, the better response of the N2 disease.
Well,
you go.
Two things. One about the percent RVT question. Part of the reason I'm hesitant to offer adjuvant IO to a patient who has greater than 60 or greater than 80% RVT is that patient may develop an immune-related toxicity that then prevents them from getting onto a trial that is actually bringing appropriate therapy to them when they do recur. So often in our tumor boards, we'll discuss, yes, and we'll tell the patient, look, you have a very bad prognosis with this. We could offer you this treatment, even if there isn't really much evidence that it benefits you. The alternative would be to enjoy the time you have. And when it comes back, we will get you on a metastatic clinical trial that is appropriate, because they have failed the first line systemic therapy for metastatic disease. And I think it's better to accept that, not induce more toxicity, and then prepare the patient. Of course, trials that are dedicated to that are important. I don't know if you have an answer for the N2. I mean, I think these patients are exposed to a lot of neoantigen. They have a lot of opportunity for interface between their immune cells and the tumor, and seem to respond just as well as those patients with N negative. But maybe we'll get on to...
Is this your question that asks about leaving them in for adjuvant therapy?
You mean my question on the QR?
Yeah.
Actually, the third question. I think I'm curious about the lymph node dissection during this neoadjuvant immunotherapy stage, because if when we, after the inductive therapy, we restaging the patients and got a negative results of the lymph nodes, do we need to do a systematic lymph node dissection with that negative positive lymph nodes?
So I think it's a couple of things. One, I typically don't invasively restage my patients after induction therapy. I simply go right to resection.
Mm-hmm.
I don't really know at that point if leaving the lymph nodes in helps them better respond to their next round of immunotherapy or not. I think that's pretty, I don't want to say it's out there, but it's
experimental.
It's very experimental.
Yeah.
And I think the prognostic value from the lymph node dissection far outvalues that.
Yeah, it's just from like animal studies and basic science, but maybe not for human right now.
Not quite yet. All right, you got Dr. Miller behind you.
Jonathan, just great case. Thanks for showing that. Linda and I was about ready to have a heart attack right when you had that cut right there. My question is that, like on that patient, and I think we talked about this at World Lung a little bit, what I've seen is when they've had N1, N2 disease, and you repeat their PET before you go to surgery, and if those nodes are positive still on PET, I've been able to do that more minimally invasively so it's not as desmoplastic. But if they have no activity at all, there is so much fibrosis, desmoplastic reaction, and I'll tell the patient, you know, there's a 10, 15% chance we'll have to open. So going into that, and just like in your case, was those nodes still positive, or were they negative on PET? Or?
So we didn't repeat a PET. And when we did the ISLC recommendations, we didn't insist. We said PET, obviously you can do it, but we didn't say that you have to do it, because you would have to do about 20 PET scans to find one patient with metastatic progression. But I agree with you. I think there's actually a lot of information in the PET that we're not sourcing. And I think we probably should be doing them more on a research basis. I can't give you data at this point to say to what extent it's informative.
Right. Well, I guess, I mean, I think what you're saying is valid, and I think evidence from Mara Antonoff from MD Anderson, not with chemoimmunotherapy, but just with induction chemotherapy. And they said, you know, what were those things that put us at risk for a bad and challenging resection? And response to therapy was one of them. So big N1 disease, response to therapy, those were the things. And I do have a very different discussion with my induction patients than without. And we talk about, you could get open, you could get this, you could get that, because I think this is still real risk in what we do. And I don't want to feel bad about conversion. I don't want it to be a sin.
Okay. And then also, too, I had a question which I'd sent in about related to smoking after surgery. Because what is the effect of the adjuvant immunotherapy when someone continues to smoke? Is there an issue with their immune system, which their immune system's already kind of jacked up? Because, you know, they had their cancer, they stopped for 2 weeks. Hey, great, thank you for doing that. And then they start smoking again, but also they're getting adjuvant therapy afterwards. Is there, I don't have enough patients to look at that, but are they continuing to affect their immune system, you know, twofold?
It's a super interesting question. I've unfortunately too many patients who continue to smoke through their neoadjuvant therapy, and I'm not sure. I think there's an opportunity there to do some science about the impact of continued smoking on response to chemo IO. Obviously, to your point, like to what extent that will have downstream effects for the receipt of adjuvant. It's clear that the smokers are the ones who benefit the most from this stuff. Is it because of a biology effect? Is it a contribution of active smokers? Is it possible that active smokers respond better? I mean, the inflammatory consequences could fit. It's not impossible.
And even the ones that clear their DNA and they develop recurrence, was it because they were smoking?
Sure. Yeah.
So I mean, it's something to look at.
I think. A lot of the talks at these meetings so far have been from these phase 3 trials because there's been so much data. But I really hope that in the coming years, it's us as a surgical community generating these data and answering these questions through new projects that come through, because we're really kind of been gifted an opportunity to really understand the biology of these new therapeutics. And so hopefully we do that.
Great. All right. Thank you.
I'm going to go to the iPad for a minute. Stephen Broderick asked kind of 2 questions about getting ready for surgery. First, what kind of tests do we do to get ready? And do we add things like thyroid function tests and, adrenal testing? And 2, what about timing? And I think that's a really interesting concept, the timing. A lot of our trials made a big deal about 4 to 6 weeks. I think a lot of that comes from chemo radiotherapy trials, and I don't know how relevant that kind of 4 to 6 week time frame is. I actually would love for, to see a little bit of that data about responses, complications, and EFS based upon when you go to surgery. I don't really think it matters. And if I have noted when we've gone from 3 to 4 cycles pre-op that my patients look a little worse now, and I'm delaying longer to try and give them chance to recover, and I'm not feeling like things are different. I haven't added all of those other studies looking for the itises, but many of my oncologists are regularly following those stuff. So I can't tell you if everyone has had it checked within 6 weeks of surgery or not.
I think the restaging question is pretty central. Again, when we wrote that ISLC consensus, we've had to respond to a letter that basically accused us of saying that we shouldn't restage and invasively. And I don't think that's the case. A patient who has evidence of progressive disease, if you feel the need to rule out N3 disease, or if you decide to do a PET and you see immune flare, it may be pertinent to do invasive restaging. But that's another area of unmet need in terms of generating evidence that should be easy for us to do as a community to explore the value of restaging and whether we should or shouldn't modify our surgical conduct according to invasive restaging.
Just a really quick comment about the itises. There's a great paper, and I can't remember who all is on it, but Jamie Chaft led the charge with it, with I think her critical care people. And it just talks about what the itises are, how to look for them. And I really highly encourage you all to read it, but also to share it with your anesthesiologists and your intensivists, because I think they're totally in the dark about this stuff.
Yeah, we need to be better doctors about all this stuff because it can be subtle to pick up, especially if you're not tuned in. And in this case, we think about it all the time, but it wasn't a typical presentation. We thought it was just a bronchial anastomosis problem. But there was more to it than that, and it's worth even implementing these things into your pathways to be checking AM cortisols and stuff like that.
Yeah. One more thing, I'm going to look at questions regarding past-CR and ctDNA clearance on deciding who goes to surgery and who doesn't. So ctDNA, we don't find it in everybody. It is still not prime time, and it's not something I would recommend in deciding surgery or no surgery. And in terms of past CR, it's like the esophagus. We don't know who's a past CR until the pathologist has the specimen. So is that a population who maybe didn't need surgery? Maybe, but we are certainly not at the point where we can stop operating based on what we have.
Good.
All right.
We're at time, so I think we're all done, eh?
I think we're done. Please go online and complete and submit your